Today we want to talk about alcohol use disorder and some of the medications that can help people. My name is Dr. Matt Campbell and I'm an addiction psychiatrist, so I've gone through a whole host of years of training with an extra specialization in addictions.
Okay. That's like 10 years of training. That's a long time. Okay, so you have a special focus on addiction.
Exactly.
And you want to talk specifically today about alcohol, medicines for alcohol use disorder.
Exactly.
What is alcohol use disorder?
So whenever we use these terms, these come to us from the DSM, and so I won't get into the weeds of the perfection of the DSM or diagnosis and all that, but it's really the basis for our studies. And so we use these diagnoses to make sure that the treatment we're offering actually has good evidence base to help people.
Okay, and some of the treatments that you have are medicines. What are they? What do we need to know about them?
So I always break them into FDA-approved medications and then those that we use off-label. So FDA-approved medications are Naltrexone or Revia, Acamprosate, and Disulfiram. Those are the three main meds that are seen and used most often. And I would even really say Acamprosate and Naltrexone are by far and away the most commonly used and the best medications for alcohol use. So Naltrexone works by blocking the opioid receptor. Opioid receptor system is mostly connected to pain.
Oh.
And so a lot of people are on painkillers. Like we know about the opioid epidemic. We have a lot of fentanyl overdoses. People had been using heroin, oxycodone. All of those act on the opioid receptor.
Okay.
And that works by addressing the pain system of the body.
Okay.
There is an overlap, and I don't know how clearly to demonstrate, but I'll say that there's an overlap between the opioid system and the dopamine system.
Okay.
So most drugs of abuse, they eventually are triggering the dopamine system.
To make you feel high and happy?
To make you say, do this again, do this again, do this again.
But it's a happy feeling.
It's a good feeling, yeah.
Okay.
It's definitely a good feeling if you've ever eaten a whole bunch of chocolate. Those first few bites, the first few bites, right? When it feels really good and you're like, this is why am I depriving myself of chocolate all day long? That's dopamine.
Okay.
Before you may feel hungover or sick of it, but the feeling of like, oh my gosh, this is the best thing I've ever had, that's dopamine. The best overlay I can say between that is, say you've done something or someone has gone and broken their leg, or they've been in a car accident, or something has happened where their body's been hurt. There's actually your body system to take care of that pain, right? So if you've noticed when that acute pain hits and then it starts subsiding, you may feel more relaxed, you may feel that kind of pain calming. That's the opioid system. It's actually, spicy food is another place that people can get that hit. So some people love the spicy food to feel that kind of
well, so is it, like those extreme stories of mountain climbers and they lose their leg but they feel no pain for 5 days when they're walking the woods, and then when they see a car coming and they see another human who's finally going to take care of them, then they feel the pain? Those 5 days is like opioids.
There's definitely opioid. I mean, there's a lot of adrenaline and other things going on, but definitely opioids contributing to that.
So opioids in a way like numb the pain?
Yeah.
Okay.
What we can say is there's some overlap with the dopamine system and decreasing cravings. So when we subjectively look at people and we give them naltrexone, animal models, human models, we can say like the subjective feeling, the feeling of like, I want to drink, that kind of urge people experience, that is less when they take naltrexone.
Okay.
I would not say that everyone is going to just stop drinking immediately. Many people will cut back, or they will just drink less intensely. So there's actually, in some places of the world, like in Europe, I believe, they have some routines of taking it just on the weekends for some of the people who actually have much more trouble on the weekends of drinking very heavily. And it'll,
naltrexone?
Of naltrexone. And it'll decrease the amount of alcohol they'll consume on the weekends. And say then the rest of the week they don't really have the cravings, they don't have the urges, their life is set up in a way that their drinking is really in the weekends. So there's flexibility in naltrexone, and there's a way in which even if someone doesn't completely stop drinking, they aren't drinking as many days, they're not drinking so intensely to where a lot of the problems with drinking may be improved.
And is that success story with naltrexone? Like, when do you say, okay, the drug worked? And is it them just drinking less or not drinking at all?
I think at the end of the day, success really comes from the patient and what their values and goals are in treatment. I will say, as someone who works with a lot of people, I think the importance is we're always looking at where we're aiming and are we moving in that direction. And so I think for most people, anytime we're decreasing the amount of drinking, decreasing the amount of really heavy drinking, that's moving in the right direction, and that should be something that we're reinforcing, we're doubling down on.
Is that a misunderstanding you see a lot in your work?
Very commonly, within families or people around kind of the environment, they understandably have a lot of hurt and pain typically. And so when they see someone drink again, they have a lot of worries that are wrapped up in that. And so even if someone is moving in the right direction, they know where that can go, and they've seen it and they've been hurt by it. And so I think a lot of people, they think that it's either there's no drinking ever again or it's a failure.
Okay.
And I think, for the most time when we're talking about alcohol use disorder, not drinking is the right and the best outcome. But we have to really say is there's a lot of ways to get there. And I think there are many people who we want to start with, or who maybe feel able to start with decreasing or cutting back. So naltrexone, because it blocks that pain receptor, if someone is taking opioids, painkillers, heroin off the street, fentanyl, methadone, any of those, and you take naltrexone, you're going to actually go into a really bad opioid withdrawal. You're going to be miserable. So you can't take it. And we have to make sure that you really are upfront about that, because it's going to be a terrible experience for you.
Okay.
Potentially dangerous to take naltrexone for those people. As well as we want to be considerate if you have an upcoming procedure or something where you're going to need those pain medications, we maybe want to steer clear from that, or at least, be mindful of a discussion of how that would work. I think the other big thing that people want to look at is their liver. So the risk is that we want to make sure that there is a black box warning on their liver, and so we have to monitor that with blood work. It's not super frequent, but we want to make sure we're checking it to know that their liver is not getting irritated or starting to get injured by the medication.
What is the next drug we want to talk about?
Acamprosate, which some people will call Campral. It's the brand name versus the generic, and Acamprosate works definitely differently than naltrexone. Okay. It also has to be taken 3 times a day. So some people don't love having to take medications frequently, and understandably, as someone who's had to take a medication, it's tough to remember. And so adherence can actually be a big problem when we're trying to figure out these medications. But Acamprosate actually works on the NMDA and GABA receptors, which I don't think we need to get into what all of that means, other than when someone drinks heavily for a long time, there's brain changes. The receptors change and how sensitive or how desensitized they are, right?
Okay. So it's usually D, and it's not more sensitive, it's usually less?
Well, for these 2 receptors, one is more, one is less.
Okay.
And so Acamprosate actually kind of goes and stabilizes that imbalance to where it's a little bit back closer to what someone who's not drinking is used to. And that's why I like to think of it as, there's acute withdrawal that is more of a medical concern that we need to make sure get through safety, because that can lead to death if it's not treated appropriately. If someone is drinking heavily to a point where they could have seizures, they could go into delirium tremens, they may need to be in a medical, like a hospital, to be monitored closely, given fluids, given thiamine, given medications to get them through that.
And so you're saying you don't want to give this drug to a person in that situation?
It's not dangerous per se, but it's not going to help them. We need to make sure we're giving them the meds. It's going to be safe to help them get through that period. Okay. Usually we want to worry about giving this medication when someone has a little bit more sobriety, because that's going to be more likely to help them. It's that later stage that they seem to get benefits from. Okay.
So what's the ideal candidate that you would, just as an example, give this drug to?
So I use this medication a decent amount. I will say the ones that tend to be the most successful with it, say someone who's in an inpatient rehab setting, they've gone through any sort of detox withdrawal, and they're really motivated to stop drinking completely. They don't want to drink on the weekends. They don't want to keep drinking, but they're having a hard time stopping. But their end goal is, I'm done drinking, I want to stop. So it's more likely to help them maintain that sobriety and prevent them from going back to drinking.
Okay. And it's so interesting, the flexibility of the first one, Naltrexone. You could just take it on the weekends, but this one you take 3 times a day, forever? At what point do you, I guess, come off of it? If you can just go on and off Naltrexone, what do you do with this one?
So I would say both medications, it's best to make sure you're working with your provider and being adherent to them, because non-adherence can really impact how much success you're having. But when someone looks at like, can I come off it eventually? I would say that if that's someone's goal, these medications, they can come off eventually, but it's really an evaluation of how long of sobriety have they built up, what kind of things can derail them, what kind of supports have they built in, what kind of like therapeutic skills have they learned.
So this is where the social...
Yeah, we want to make sure that they're set up to succeed. There's also the people that say they've tried everything and they had a hard time quitting, and then they went on Naltrexone and they were able to stop. Those people, you may want to really stay on a little bit longer if it seems like that was the key ingredient. But I would say most people, you're getting a lot of these things together. And so after, closer to a year is when you really have a sustained remission.
Okay.
Those kind of time frames, if you've really built up a good support system and a good strategy, I think looking at coming off medications is very reasonable.
Okay.
Disulfiram or Antabuse.
Works. This is the first one that works not in the brain. Is that correct?
Yeah, this one works more in actually preventing the clearance of alcohol.
Okay.
And so normally you drink alcohol, it goes through your body like many things. It's metabolized in your liver, and then you get rid of it. So Antabuse prevents the full metabolism of alcohol to where you actually build up acetaldehyde, which is very unpleasant to get in your body.
Wait, like the Asian glow gene?
Yeah, it actually works on that same enzyme.
Okay.
Very, very similar.
Okay. So it gives you like an Asian glow effect? Like, because when I get Asian glow, my body is rejecting alcohol. I get itchy, I get this, I get that. Is that what it is?
Definitely nauseous, vomiting, feeling sick, flushing. People, though, with different heart disease or respiratory disease can be more dangerous. People not necessarily taking it because of that deterrent effect. It's not something that I use very frequently.
Okay.
I would say the cases where it's most likely to be helpful if you are using it is, say you're in a controlled setting, like a rehab, and there's a very high risk of relapse, but you're going away for like a weekend or a day, and it's those first bouts of sobriety that maybe you can take it in that morning before you go home, where you're in an uncontrolled environment, but like, hey, this is in my system, this may not go so well if I do drink. Or you have a very supportive partner, say you're married and your spouse really doesn't want you to drink. There have been studies more with like behavioral type therapies where that spouse is observing whether or not they are taking the pill every morning. And that kind of feedback and them working together with the provider is more likely that they're going to be adherent, more likely that they're going to stay on track.
That's kind of sneaky.
Well, the difference is it's not the partner is chastising them and yelling at them to take the medication. And they don't make them take the medication. It's not that kind of strategy. It's more that they're there and they're observing whether or not they take it. So there's just that accountability.
So do you ever use these in combination? Like you use one to bring the drinking down and one to maybe be this barrier when
and these are great questions because you look at it is these aren't 100% successful for a lot of people. Like a lot of people don't just take this and then they never drink again. A lot of times people may take a medication and they may be like, maybe I need more medication. It's not fully gotten me to the place I want. The meds do help a lot of people, but even if you get 90% of people, 10% is still a significant group that want something more.
Okay.
And so there's a lot of questions like, what do we do after we try one medication? And can we combine? Can we use all three together? And generally speaking, you can individualize this to some degree, but there's not great evidence to be like combine 2, combine 3, that this is more likely to be helpful.
Even along the length of the journey, not at the same time, but like in different moments?
In different phases?
Yeah. You
could think about them strategically in that way, but there's not a whole lot of really great evidence to guide you in that. It would be more of you kind of individualizing something for someone. Okay.
If we pivoted for a second, what would you like to debunk for people?
Where to start?
Yeah, sure. Go ahead.
I would say one of the biggest fears that I get from someone who struggled with addiction is they don't want to be dependent on a new drug.
Okay.
Which is very understandable. And I think there is a way in which some medications we can think of more similar to that way. But these medications, Naltrexone, Acamprosate, Disulfiram, these are not dependence-forming medications.
Okay.
These are not medications that you take and then your body adjusts to them and becomes dependent on them, and you're going to have a withdrawal if you stop.
Okay.
And that's part of the reason I talked about you can look at coming off of these in the context of a treatment plan and what's working, what's not working, and what level of success you're having and how important it is to your level of success. But they're not things that you're dependent on in the way that your body will start having headaches or nausea or vomiting, or you won't be able to get up if you don't take them. They're not like alcoholism that way.
Do you see, does that mean that people are asking that because their loved one, whoever's suffering and struggling with alcohol use disorder, is taking these for really long periods of time?
Yeah, I think for these ones specifically, we see it from families. We also see it from patients. So families, I think a lot of times they're worried about the ultimate function of that person.
Okay.
And they want to see that person living a full life, right? Doing all the things that they maybe used to do or that person would like to see them do. Mm-hmm. And they worry that if they're not doing that maybe the medication is what's holding them back.
Okay.
I would say when we're talking about alcohol, that's very unlikely to be the cause of it with these medications. These medications are likely to help decrease their drinking, but they don't necessarily, unless we're looking at some of those psychosocial things, they don't necessarily get them to the full function unless decreasing drinking is the only thing that person needed, which many people do. Many people, you cut out the drinking, they're able to just naturally regain some of that. But a lot of people need the psychosocial interventions to help them work on their function overall.
So again, the marrying of medication with psychosocial therapies and other interventions. Mm-hmm. Okay. Any other myths to debunk? Just giving you
I think a lot of times people have heard of the vomit medication.
Okay.
And they think if I'm going to take a medication, that's the medication.
Why?
Because it's just it's talked about, it's heard, it's in.
But why is that the one that they want? They want to vomit?
No, not the one that they want to take, but that's their idea of taking medications for alcohol. They don't necessarily realize that there's 2 other medications that don't have any sort of problem like that.
Okay.
That even if you drink, you still take those 2 medications because they can still help you even if you do drink. And so you do get a lot of people who either they're afraid if they take this medication that they will still drink, so they don't want to take any medication. Mm-hmm. Or they will stop taking medications because they don't want to have a problem because they're planning on drinking.
Right.
So something like Naltrexone, even if they plan on drinking, they're like, you know what, this weekend I think I'm going to drink. For whatever reason, they should still take that medication because if they go back to drinking, they're likely to drink a lot less than if they stop the medication. But it's not Antabuse, it's not Disulfiram. So if they're taking Disulfiram and they drink, they're going to be miserable, potentially dangerous. So they those ones, I can see why they wouldn't want to take that medication because they may have a little bit more ambivalence about their drinking than they care to admit.
There's more drugs than the vomit drug that can help you.
There definitely are.
Okay. Any other myths to debunk?
What it means to either use medications or not. And I think it's always important. I like to look at medications or whatever intervention we're doing is first let's understand where someone would like to be. So what are their goals in their life? What's their values? What's their plan? And what's getting in the way? And here we're talking about alcohol use disorder. So that means we're admitting that alcohol is getting in the way of where they want to be. And so at that point, it's like, well, how do we get to the mountaintop? What's the gear we need? What's the strategy we need? What's the team we need to help us get to the mountaintop? And alcohol helps a lot of people. The medications help a lot of people. Okay. And so I like to use them along with everything we can, because we want to get to the mountaintop. And it doesn't necessarily matter so much of like, I don't want to use any tool or gears or anything that's going to help me. It's just, I want to get there.
You've got to have gear to get to the top of the mountain. You have to have, What are the other, what's the rest of the team?
Yeah, so, I mean, when we talk about all of the tools, there's people, but there's also interventions. So sometimes we talk about medications as an intervention, but we can talk about CBT as a type of therapy. But
Cognitive behavioral therapy.
Yeah, so there's a way to get that intervention. That means find a good therapist who's trained in it. Maybe there's group modalities that we're going to try to get these interventions across. So the intervention is CBT, but there's a lot of ways to get the CBT is what I'm trying to say.
In a group or one-on-one?
Yeah.
Okay.
Sometimes apps. There's ways in which we try to get this across. So it's important that it's there's a lot of different interventions and there's a lot of different people, and different people may be bringing different interventions to the plan. Someone is starting to make this change. I think having a good treatment team, which would be the professional setting, and they would be the ones trying to help you make sure you're getting good evidence-based therapy, really looking at the social interventions and evaluating for any medications and comorbidities that are going to be helpful. But I also think peer-led interventions, things like AA, are incredibly helpful. If people have family members that are interested, letting them go to Al-Anon or other family things that they can do. Even peer counselors, which might be kind of in the professional, but maybe cross over that line as well. This has been another episode of Conversations with AcroPsych, hosted by Dr. Matt Campbell. Thank you so much for watching. Please leave a comment below for the topics and resources that you want to hear about as our next general educational topic. This video and all information put forth is for general educational purposes. It does not form a doctor-patient relationship. It does not provide any medical advice or individual care. It is in no way a replacement to your medical professional, and we recommend seeking appropriate professional assistance with all your healthcare questions and needs. For any psychiatric or medical emergencies or any safety concerns at all, please utilize appropriate emergency services. This includes 911 or going to the nearest emergency room. For needing to speak to a mental health counselor, there is 24/7 hour hotline that you can reach a crisis counselor.